So hey everyone, my name is Iyad. I am the educational officer at UIMS, and I've worked with UIMS for about 9 months now. And my work is to introduce and participate and obviously organize events related to educational services. So today we are ready with our fifth installment of our radiology series. Our speaker today for this lecture is Dr. Sajeev Sridhar. He is currently working as a standalone FY2 at Hull University Teaching Hospitals Trust. He graduated from Masaryk University in 2020. His academic interests lie in diagnostic technology, namely radiology, including the advancements made to deal with the high throughputs of scans radiologists face in today's medical climate. He's also interested in interventional radiology, particularly vascular oncological interventions such as TARE and TACE. This lecture will be an introduction to head CT. So thank you so much, Doctor, for being here, and we're looking forward to have you. Thank you so much. You can share your screen and start whenever you feel comfortable.
Thank you very much for that, Rosmia. Thank you. Right, okay, so just gonna dive in straight. Let me just share my screen with you. Go. So, can everyone see the PowerPoint? Full screen it. Can someone just put up on the chat box if everyone can see it? Excellent. Okay, good stuff. Right. Okay. So as Iyad mentioned, so today the lecture is going to be just a brief introduction to CT Head. I'm really sorry that I'm not looking that well. I just woke up from a nap as well. I was on nights last night, and I'm going to go on nights again tonight. So at the moment, I'm doing ED. I'm in my last rotation as an F2 in Hull University Hospitals. So honestly, the first thing I'd say is that for anyone that wants to come to the UK, I'd really recommend them to do a standalone F2 because you'll be getting a UK FPCC, and that is something a little bit more valuable than a crest because it makes you look like a more well-rounded person as well. Right. So without further ado, what we'll be discussing today. So today, I just want to do a quick recap on what I've already sort of spoken about in chest X-rays, particularly about what X-rays can actually do and how it is that is different when we are CTing someone as opposed to just an X-ray. We'll be looking at the basic anatomy of what you have to look out for in a CT head. A conventional approach, I'm not going to go into too much in terms of the approach itself. The reason why is because this lecture, it is sort of mainly focused on the on medical students, especially ones who are about to become F1s, F2s, something like that. If I were to go into a lot more detail, then it would just be confusing. So a basic approach will be go after, and then in this lecture we'll be going over a couple of pathologies, but the bulk of them will be covered in the next one. As well as that, there will also be a quiz at the very end, and you can ask me questions at any time, and I'll try my best to answer them. Okay, right. Recap. So obviously that is a picture of a CT head. You can see the brain very, very clearly. Now, I don't need to point out that the top is the anterior, the bottom is the posterior. And particularly with the way you're viewing the CT as well, the left is the right side of the patient and the right is the left side of the patient. Now, in my lectures about chest X-rays, we can say that the image itself that we see, it kind of shows the regions of the body where the X-rays have penetrated and the regions where they have particularly been absorbed. The absorption of these X-rays actually depend on the density of the structure, and basically the differences in densities allow for the X-rays to either be passing through them or to be absorbed. Now, brighter regions on an X-ray or even in a CT, they indicate structures that are more dense. So these kind of structures would include structures like bones, metal, any artificially placed devices, as well as any kind of abnormal calcifications. Now, I say abnormal, some calcifications are normal and age-related, some calcifications are abnormal. And on the contrary, any structure or any kind of region of the X-ray or the CT that is darker in color, that would represent less dense structures. So in the case of chest X-rays, we'd be thinking about air, we'd be thinking about water, we'd be thinking about fluids in general. Now, in the case of a CT head, there shouldn't be any air. Okay, if you see air, then it's something that is definitely abnormal. It's not supposed to be there, and you should immediately be, it should be an emergency. But regardless, this is a basic principle. And this principle in X-rays also applies to CT. So anything that's brighter is denser, and anything that's lighter is less dense. Okay. The only difference here is that we are actually creating a three-dimensional image in a CT. So that means that X-rays are blasted through the body at all angles. So that means that we're actually able to get a really good cross-sectional image of the different densities of the tissues there are within the body itself. And the specific thing that we're trying to get here is the resolution of the CT scanner is focused on how well it's able to differentiate voxels. Now, in a two-dimensional image, we are thinking about pixels. Imagine just voxel as being a three-dimensional pixel, that's it. And particularly important is to note how we define the densities in an X-ray, or in a CT, sorry. And we define that as a measure on a Hounsfield scale. So we categorize each and every single, or we kind of give a range for particular densities, and we classify them according to the Hounsfield units itself. Now, what's a Hounsfield scale? So this is basically a simple interpretation of what the Hounsfield scale is. It is a scale that ranges from -1000 to 0. Yeah, it's from -1000 to 0. And it's conventional that water is 0 and air is -1000. Anything that is denser than water would be categorized above it. And we can technically go even beyond 1000 by that definition. But for the purposes of what normal structures there are in the body, and for purposes that even artificially placed structures, so be that, you know, a pacemaker, be that any kind of shunt, be that even a bullet, for instance, these structures, they are all still kind of within the confines of about 1000 or just less than 1000. Right. Like I said, it's a very important measure. Cortical bone and metal is around 1000. Soft tissue is about 50. Fat is about -100. Now, these are the key points that you have to definitely look out for. So these are the key sort of numbers that you have to remember. Now, like I said before, in the brain, we are only dealing with the ranges of between water and +1000. We're not expected to find any kind of air. We're not expected to find any kind of pure fatty substance or anything like that. Yes, there is definitely white matter, and the white matter is composed of myelinated axons, and these myelinated axons are predominantly fat, but they're mixed in with other structures as well. So therefore, overall, their Hounsfield unit is actually quite a bit higher than water, to be honest. Now, apart from that, what other structures are there? We're dealing with gray matter. Now, gray matter is basically the thinking part, and the thinking part of the brain itself is located in the cortex. And you also have some deeper gray matter tissues, and these gray matter tissues involve the basal ganglia, as well as parts of the cerebellum as well, and they are just neuronal cell bodies. Okay. Now, just to give you a quick idea, CSF is not exactly pure water. It is still a little bit more denser than water. So CSF is about, I'll answer that in just a moment, Mariam, 1 second. So let's just deal with the normal structures first, and then we'll get to pathologies later. So CSF, as I was saying, is basically about +15. So it's still a little bit denser than water. White matter would be in the range of about +25, and then gray matter would be in the range of about 40. The key thing that you have to remember from this is that clotted blood would be in the high 80s, in the 80s, 90s, 70s, something like that. So if at all you see anything that is in that range, if it's all, and it is quite obvious, to be honest, particularly if we're dealing with acute intracranial bleeding, if we're dealing with strokes, particularly vascular issues, you should be able to spot that quite quickly. And it is generally more dense than the rest of the brain. Now, the main thing to take away from this is that because the densities, or because the Hounsfield units of these different structures are so close together, we rely on the TACE software to help us and guide us, particularly in making certain diagnoses. Particularly, we use this feature called windowing, and windowing basically allows us to alter the contrast, allows us to alter the brightness, and many different parameters of the actual image that we're seeing, or the actual cross-section that we're seeing, so that we can better view the image itself and are able to identify structures more easily. What I want you to take away from this is that basic principle is that CSF is near water density and that the gray matter is denser than the white matter as a normal. Right, let's get into the anatomy. Right, okay, so for this, yeah, can you stop recording for a while, because I do need to get into the other software. Is that okay? Approach. Excellent. So the next thing that I want to talk about is the approach itself. Now, here's basically how to actually view the CT without missing any of the important signs. It's very, very easy to miss important parts on a CT. The reason why is because it is a lot of information to take. And I know that the kind of example that I've given you, the kind of cross sections that I've showed you, it was a very, very wide cross sections. They were not really that detailed, but if ever you do request a CT scan, you'll be given a 5mm cross-sectional images, and you'll also be given 0.5mm cross-sectional images. It kind of ranges from hospital to hospital, but in general, most of the hospitals in the UK that I've worked in, they always give you these two options. There are also ones that give you 3mm and 0.75mm as well. But generally, the narrower the slices, or the thinner the slices, the more detail there is. And so you'll be able to appreciate many more of the structures as well. Now, like I said before, always start from the top. What do I mean by that? I mean, you have to always start from the very, very top of the actual CT head itself. You have to visualize the central sulcus, see if everything's okay over there, and then proceed downwards. Okay, because you should not be missing out anything. So that means all the way from the top and then go downwards. Okay, and I cannot stress that enough, because there have been strokes that were not picked up because they just started seeing them from a mid cross-sectional point of view. Okay, and unnecessary MRI scans were subsequently requested because they just thought there was no stroke, but the patient was still presenting with the clinical symptoms of a stroke. And the MRI then obviously picked it up, and the radiologist clearly reported that there is a stroke. Why wasn't this picked up on the CT? And even in the report, they mentioned that it was already picked up on the CT as well. So always start from the top. I cannot stress that enough. And it'll also give you a good idea of if there are any kind of pathologies already with the CSF, because if there are if the hemispheres are not symmetrical right from the top itself, then you know that there is something going on. There's something unhappy in the brain. Okay. First thing that I would always recommend doing is generally scrolling. Okay, so generally scroll up and down really, really quickly, just to see if there's any kind of anything that catches your eyes. Okay, it kind of allows you to kind of point out if there's any masses, any bleeds, anything really, really quickly. Okay, if nothing pops up, then start to look at specific things. The first thing that you need to definitely look at are mass effects. Now, mass effects are things that it has been pointed out in many times where junior doctors are not good at picking them up, or at least picking them up early, just because they're so subtle. Now, mass effects don't have to involve deviation from the midline. It doesn't have to involve very, very strange CTs. It can be very, very subtle. The main things you need to pick up are the herniations of the results of these mass effects. Those are the main things that you do need to pick up. Next thing that you need to rule out, any bleeds. Now, as I mentioned, bleeding, it's kind of complicated when we're dealing with the brain, because you're dealing with several different components of bleeding itself, because you have different timelines. We have the hyperacute bleed, we have the acute bleed, we have the subacute bleed, and then we have the chronic bleed. Each of them have got a variation in terms of how dense they are. And I'll get back to that as well later. Now, in general, the main thing that you do need to remember is that hyperacute does not look like an acute bleed that is clotting. An acute bleed will not look like a chronic bleed that's already clotted and kind of is resolving in itself. Okay, and we will get to that as well. The next thing that you need to definitely rule out is any kind of stroke-like signs. Now, there are three main signs that a CT will be able to show you that is more representative of a stroke. If at all but I just want to make it a point over here that when we are dealing with anyone of suspected stroke, your clinical diagnosis, it is of paramount. Okay, a CT does not diagnose stroke. A CT will only allow you to rule out if there's any kind of bleeding. Clinically, if they have a stroke, they have a stroke, and you have to deal with it from that point of view. Start giving aspirin if the CT does not show any bleeding. If it does show any bleeding, there are anticoagulants, and we can think about other options. Even consider neurosurgical referral at that point. But the main thing is just look out for any stroke signs. If there are none present, they're still clinical, treat them as stroke. If there are stroke signs present, think about how acute the stroke is. Is it hyperacute? Is it acute? Is it subacute? Or is it chronic? And if it is chronic, why are they presenting with those signs? Could that be just post-infarct seizures? Could it just be one where they had another TIA? You should start thinking about things like that as well. And finally, what you do need to check are the soft tissues, like for instance, the fat, the connective tissue, the meninges. So these all come under the scope of any kind of infections, any kind of tumors, any kind of masses, and so on and so forth. And last but not least, the bones. So we check for any kind of fractures. So this is the kind of approach that I would recommend, particularly if you are working in a very fast-paced ward. So for instance, like ED, or for instance, like AMU. Okay, so these are the kind of things that you would definitely have to rule out really, really quickly, even before the CT report comes out from the radiologist. Obviously, you have to wait for the CT report from the radiologist, but regardless, you still need to be able to identify these things very, very quickly. Right, so let's start off with bleeds first. Okay, now, as I mentioned before, acute bleeding, acute blood itself has a Hounsfield unit of about 80 plus. Okay, the main thing is that subacute and chronic bleeding will appear similar to gray matter, white matter for subacute, and chronic will appear more to CSF. So this is what I mean by they appear differently to what acute blood is like. Okay. Now, because of these differences, you can draw various other conclusions based on what the actual pathology can be. As I mentioned before, you should not confuse acute blood that is clotting, with calcifications. Calcifications, as I mentioned before, you can find them in several parts of the brain. You can find calcification of the caudate, you can find calcification of the choroid plexus, you can find calcification of the pineal gland, and so on and so forth. And because choroid plexuses are pretty much in every single ventricle, you can find calcifications of that you should not misinterpret for any kind of bleeding. There is a feature on many PACS softwares where you can actually calculate the Hounsfield unit on the area where you have your cursor over as well. So that will also allow us to kind of gauge as to whether we're dealing with acute clotting blood or whether we're just dealing with calcifications. So what kind of bleeds do we know already. So what kind of bleeds are there, first of all? Just put up on the chat, or you can just speak out. What kind of bleeds are there? Within the brain, that is.
Epidural hematomas, subdural, subarachnoidal, and intracerebral.
Excellent. Well done. Well done. So as Tim pointed out, we've got a couple over here. Okay. So the CT on the left is a classic appearance of an epidural hematoma. You have to pay attention to it. Epidural hematoma is the reason why it is of this shape itself is because it involves a rupture of an artery. Arteries are high pressure. High pressure means the blood just comes out, gushes out very, very quickly into the epidural space. The main features of this one are that it is very, very convex in appearance. And usually it's a result of some kind of trauma. So in this case, we can see that the patient had some kind of knock on the right-hand side of the brain. And you can see the subcutaneous hematoma that is formed on the side of the brain as well. And obviously there must have been some kind of knock on the left side as well, because you can see a slither of subcutaneous hematoma over here as well. The key thing to note is this is acutely clotting blood. But even within this acutely clotting blood, you can see instances of sort of this darkness. Hang on, let me just get the pointer out. There we go. You can see these sort of areas of darkness over here, and over here as well. Now, can anyone tell me what these areas are? What do you think they are? What are these darker areas present within acutely clotting blood?
Hyperacute blood.
Exactly, hyperacute. So that is a main thing that you need to look out for. Hyperacute blood will appear, funnily enough, less dense than clotting blood. The strange thing is chronic bleeding as well will appear less dense. So you need to distinguish between those two. The easy way to distinguish between those two is that if at all you have a hyperacute sort of a picture within a context of an acute picture, that is generally fresh blood. It's not chronic. Okay. There are exceptions to that, and we will get into those exceptions in just a moment. But in general, this picture, or this CT cross-section on the left-hand side, is a classical picture of an epidural hematoma. One more thing you have to note is that these epidural hematomas, they do not cross the suture line at all. So they always are restricted by the suture lines. Does everyone know what that means? It means that they do not cross between one aspect of the bone to the other. Okay, basically where the dura itself is tied down to. Okay, now can anyone tell me what we're looking at on the right-hand side? So on the right-hand side, we're dealing with a very acute subdural hematoma. Now, subdural hematomas, as you guys should definitely know this, sorry about that, is they are due to ruptures of the dural emissary veins. They're basically bridging veins themselves. So this usually is a low pressure system, so therefore it can take a long time to develop. And by the time the person even has any kind of symptoms, it's probably already resolved in itself, and therefore some sort of a chronicity has formed, or they've already gone to the hospital and therefore they've already received a treatment for it. In either way, if at all we are dealing with an acute or a hyperacute, which is very, very rare, the treatment for this, if it is starting to bleed a lot and causing a lot of midline shifting, is drilling into the skull itself and causing a burr hole and thereby draining the blood out of it. The same would also apply for an epidural as well, if they are fast enough, and they need to be fast enough for that. Now, the other two bleeding, this is where the suprasellar cistern is very, very important, because as you saw earlier on, the suprasellar cistern was wonderfully hypodense in appearance. Here, we have this classic star-like picture, very hyperdense, and it's acute. It's definitely acutely clotting blood. Can anyone tell me what this is? What are we dealing with over here? I think Tim's already pointed this out. This is basically a classical image of a subarachnoid hemorrhage. Okay, now subarachnoid hemorrhage don't always have to present like this. They can present in other ways as well. The other ways in which they can present is if at all we have other sulci that you can see in the brain. That means everywhere else where the cortex is as well. If they're also showing a hyperdense appearance, then we are dealing with a subarachnoid hemorrhage. Probably not to the significance as what we see over here, but we are still dealing with that. And they will still present with the classical symptoms of the mother of all headaches. Okay, that's generally what they will come with. And if that is the case, immediate CT, immediate management, immediate neurovascular or neurosurgical referral. And finally, on the right, we have a classic appearance of a
Is everyone still there?